Thank you, Dr. Venkatraman. Can we have the slide projection? Right. So good evening, friends. Well, this is Jugalbandi, and we does not have made any formal slides. So we will show you only one slide, and we will like you to be involved along with us. And we both are discussing a case and also interacting with you. So this is a real world case. All of us see such type of type 2 diabetes cases in real world practice, and we manage these cases differently based on our own understanding of diabetes. So today we are going to show you a case, 55-year-old gentleman, known case of type 2 diabetes from last 10 years, BMI of 29.5 kg per square meter body surface area. Patient has some comorbidities in form of hypertension, dyslipidemia, urinary albumin was measured, it is 56 milligram per gram, which means microalbuminuria range. Patient has an eGFR of 73 ml. Family history of premature coronary artery disease is present. Fasting plasma glucose is 170, postprandial glucose is 210, HbA1c is 8.6%. Patient is currently receiving glimepiride 4 milligram twice a day, metformin 500 milligram twice a day, tablet amlodipine 10 milligram OD, and atorvastatin 10 milligram OD. Me and Rajeev, my friend, this patient is concerned and how to alleviate the concern of this patient, and in front of you, you have history, physical examination in brief, and the treatment which this patient is receiving.
So Rajesh, first important thing is that this patient is very fortunate. Usually you have to pay for second opinion, and this patient is going to get 100 second opinions without paying. So that is number one. So Jugalbandi, as GVK started, is about dialogue, deliberation, discussion, and we're going to have discussion with you also, because this is a case scenario. So my first question to Rajesh is that, why is this patient on 8 milligrams of glimepiride? How many of you all go up to this 8 milligram of glimepiride? Yes, Dr. Karnadi. Absolutely. So this is Rajesh's.
I'll come to you. See, whenever we see a patient, although we often discuss guidelines, I always said in the conferences, although we as an Indian, we are very fond of discussing guidelines, and probably in diabetes there are more than 50 guidelines, but we do not practice guidelines. So this is the reality number one. So please practice what we discuss. Now when we see this case, there are many important things historically and clinically when we are going to decide treatment of type 2 diabetes, which we should take into consideration. 55-year type 2 diabetes, duration of diabetes. While writing prescription, we never pay to the duration of diabetes. He is a known diabetic from last 10 years, and nobody on this earth with certainty can tell the onset of type 2 diabetes, which means it might be 15 years also. So duration of diabetes is very important when you are choosing therapy. Second important point, BMI of 29.5. As per Southeast Asian consideration, he is obese individual. So when you are going to choose therapy, take into account obesity, because we often ask very casually to all our patients, vajan kam kar le, vajan kam kar le. I am speaking in Hindi, weight kam kar le, weight kam kar le. But unfortunately, we write drugs which causes weight gain, and patient is frustrated. So we have to find out the reason for weight gain. Third, patient has number of comorbidities, hypertension, dyslipidemia, microalbuminuria. So patient has already established diabetic kidney disease also. And there is a family history of premature coronary. Now, so all these things should be taken into consideration when we are going to write prescription, right patient, right drug. That is a basic motto of this Jugalbandi. So, and now Rajeev has asked me 4 milligram BD.
Yes, why 4 milligrams?
So if you see pharmacology, there is a beautiful diagram. At half the maximal marketed dose of all sulfonylurea, there is a plateau. 80% of the clinical benefit of sulfonylurea comes at half the maximal marketed dose. For glimepiride, we often see even prescriptions of 4 milligram thrice a day. Now here it is 8 milligram is a maximum DCGI permitted dose for glimepiride. Permitted dose, which means at 4 milligram, 80% of the effect of glimepiride has already come. So there is no point in writing dose of glimepiride more than 4 milligram, although we commonly say 6, 8 and even 10 milligram. So I think
Rajesh, the second thing, why twice a day?
There is no point in writing, first of all, a dosage of more than 4 milligram once a day, because glimepiride is a long-acting sulfonylurea, and number two, BD does not make any case. But then, Rajeev, we sorted out glimepiride 4 milligram OD, best possible dose, but then this patient glucose is not under control.
True.
And so now we have so many different class of agents. So based on the history which I have told you, based on the physical examination, comorbidity, how will you go about changing his anti-diabetic medications?
So important to realize that this patient is not our garden variety of patients, and fortunately or unfortunately majority of our patients are like this, where there are underlying risk factors, heredity has loaded its gun, there are modifiable, non-modifiable risk factors there. He's got 4 risk factors, HbA1c is high, he's already on a statin, he's on a CCB, which we can again discuss. So now at 8 milligram glimepiride 1000 mg, I'm going to ask the house, how many people would be interested in insulin as one option? You know, reduce the glimepiride, add an DPP-4, reduce the dose, it's on 8 mg, reduce the dose, add a DPP-4, third option, SGLT2. So how many of y'all?
Fourth option, injectable GLP-1 RA.
Can I just have another option?
Yeah, please, sir.
Yeah, another option is de-escalate the SU and then have a generic combination of a DPP-4 and an SGLT2.
Okay, so whether now patient is 8.6, our goal is 6.5, so we need 2% reduction, very closer to goal. So maybe a combination which will cost probably a 1.5% reduction in, that's what Dr. Venkatraman is suggesting. So how many for insulin in this patient? Dr. Karnan, Dr. GK. So we have very fewer people who are ready to insulinize this patient. But yeah, Dr. GVK, your opinion.
And then,
So GVK, it is not insulin. So you have to precisely tell us, the house, whether you are going to start basal insulin, whether you are going to start premix insulin, whether you are interested in starting basal bolus insulin.
I would like to, because the fasting is 170 and PPG is to 210. I would rather like to put a small dose of basal insulin so that it controls.
Okay, so Dr. G, you would reduce the glimepiride.
We will come to you, sir.
He's organized. Okay, so
No, it's nothing to do.
see, small dose, 5 years. See, the first thing bedside with insulin is, if the patient is 5 years, okay, the fasting is 130 or 140. This is what we learned. Now that you are dumping DPP-4, the only drug which may be effective is SGLT.
What do you want to start in this patient?
First thing is, I don't know. I will advise is basal and bolus. Maybe if the insulin is too with the SGLT.
So your choice is basal and bolus.
Your choice is basal bolus. Dr. Lilly, what's your choice for this patient? Would you go in for 2 drugs, 1 drug at a time? Would you go like a cowboy with 3 drugs or a cowgirl?
Yeah. No, I would start with the, if a patient is willing, then maybe a basal insulin.
Everything, patient is willing, affordability is not
Patient
an
is
issue.
willing, affording,
This
everything.
is science, so we should not discuss.
No.
Patient
Basal.
is willing, affordability is there,
Basal.
affordability is there. So you tell your
What is
best
your
option.
choice?
Basal insulin,
Basal insulin.
yes.
Dr. Lakshmanan.
I think 8.6 is too much for a oral drug. whatever drug you are going to add is not going to bring down the A1C. You want to target 7, isn't it? So I may step up the dose of metformin because it's very small for this BMI. Maybe delete the glimepiride, add a DPP4 as said. DPP4, SGLT plus metformin 1 gram,
Let him speak. Let
1
him
gram
speak.
twice daily. And rightly he said the difference between the fasting and PP is not much. It's only less than 60 milligrams. So add a small dose of basal, the fasting will come down. I may add for maybe for a few weeks till the sugar settles down. I think within about matter of 4 to 5 weeks, he'll come back to the nice control. Then the three drugs with a little weight reduction, you should be perfect.
So Lakshmi,
And, yeah, and he has got albuminuria. Probably I may like to add a ACE or ARB inhibitors in this patient, along with amlodipine. Or I may stop even amlodipine. Amlodipine really induces proteinuria.
Yes.
If you ask, because it dilates both the afferent and efferent arteries of the.
So that's the
Forbes
reason we
capsule.
put amlodipine, so
Yeah.
that there is some.
So a lot of things has to be modified in this guy. Maybe step up the dose of atorvastatin, premature CAD. I think
Why you want to step up the dose of atorvastatin?
already is
Suppose LDL cholesterol
There's
is
a-
already
no.
70.
Doesn't matter at all.
Doesn't
Yes.
matter.
There's a family history. There's a very strong family. It's a premature coronary artery disease.
True.
One should be careful.
Thank you, sir. Thank you for bringing that
So-
up.
so-
So I'm playing the devil's advocate here. Why not pioglitazone? Have we dumped it? Sir, have we dumped it? CAD? Have we dumped pioglitazone? Anybody for pioglitazone here?
He's already.
Not after 10 years. It's the only insulin sensitizer we have. Nobody will use pioglitazone here.
What about lobeglitazone? Are you going to start lobeglitazone?
The data is not so.
No, it is a cheaper drug.
Huh? Yes.
I think it boils down to two things. Either it is a sequential addition of downsizing the sulfonylurea, substitute with a DPP for SGLT2 or SGLT2 alone, and then add a basal insulin, or a simultaneous basal insulin and an SGLT2 DP4 combination
So, right.
after de-escalating.
Right, we cut short it. Let's. We,
8 milligram, 2 milligram.
we have listened everybody's opinion. Now let's cut short it. Talk science. Now we have discussed there is no point of using glimepiride beyond 4 milligram. So there is no confusion. We have to reduce the dose of glimepiride. Number 2.
The problem is, diabetes is a heterogeneous disease.
We are coming
Even
to
a
that
doctor,
point.
No, doctors also thinking such a heterogeneous fashion. That's a problem.
So now, see, when we have to manage this patient, Rajeev, we have to manage comorbidities also. Now, based on the present data, based on RCTs, I am not talking about individual opinions, based on randomized controlled trial, this patient is having CKD, this patient is at a risk for premature coronary artery disease. So whatever therapy you are going to modify, that should also address these comorbid conditions, apart from controlling your glucose levels. Now, when it comes to the battery of drugs available to us, 2 class of agent must be included in whatever way we are comfortable with. Now, these are GLP-1 receptor agonist and SGLT2 inhibitor therapies.
So Rajesh is right there that, in all the guidelines other than Israeli Diabetes Federation guideline, they don't mention BMI. And BMI is a very important criteria. Israelis are the only people who mention BMI. Right? They don't talk about HbA1c. They first segregate phenotypes of patient based on BMI. So if this patient at 29.5, he doesn't qualify for insulin. If he has a deep pocket, he qualifies for something which can make him lose weight.
He hasn't got a beta cell.
But
We are coming to that issue.
He has an overactive,
We are coming to that
paradoxically
issue,
high
sir.
glucagon.
Now coming to the insulin therapy, definitely this patient need some support for insulin therapy. Now all of us are correct and all of us are wrong also. There is more than one way to initiate insulin therapy. If we see the difference between fasting and postprandial, and we understand the concept of fixed fasting first with the decreased carryover effect, probably starting basal insulin is a good option. But considering duration of diabetes, basal bolus insulin therapy might be the option.
Rajesh, why not
I am coming,
GLP plus insulin combination?
I am coming to that, Rajeev. I am coming. But then, basal bolus therapy is very good to talk about in a conference hall. When patient has to take in real world, after some days, either patient change the doctor or stop taking the insulin therapy. So basal bolus therapy might be really good option, but then we have to consider the practicality of application also. Diabetes is a lifelong disorder. Patient has to take therapy for long. So Rajeev, your question, there are now two options. We have to take care of risk factors. We have to control diabetes, duration. So if we see guidelines, before starting basal therapy, there is an option that we can start combination of GLP-1 RA with basal insulin. Now, there is a trial which is known as dual trial. In dual trial, they have compared a injectable GLP-1 RA with basal insulin.
Dual 7, where they compared basal bolus with
basal
plus
bolus
GLP-1,
insulin
yes.
therapy. So it has been found that with use of GLP-1 RA with basal insulin therapy, it is a non-inferior in terms of glucose control to basal bolus therapy. At the same time, there are added advantage that risk of hypoglycemia is reduced, which is more with basal bolus. Weight loss is seen with combination therapy as compared to basal bolus, non-inferior glucose control, and you are targeting number of risk factors like present in this patient. So my take is I will like to start a combination of GLP-1 RA with basal insulin therapy.
So the point is that we don't want him to come to an HbA1c of 6.5. We want to see what are the various modalities available. Yes, sir.
Yes, Professor Sundaram.
Sir, in all diabetic patient, I always tell there are 4 Ds. First D is diabetes, second D is diet, third D is discipline, and fourth D is drug. So we are now discussing drug, but we are not forgetting the first 3 Ds. So they are always there in all diabetic patient. If a diabetic patient does not follow diet, costliest medication will fail. So they have to be part of, you are absolutely correct.
So
Not everybody will respond to your agonist, not everybody could tolerate.
Absolutely.
You said about hypoglycemia, insulin. If you judiciously use insulin,
Very good word,
Yes,
sir.
yes.
Judicious is a wonderful word, but it varies from person to person.
Dr. Lilly, you have something to say. Yes.
Yeah, I just wanted to ask you, if a patient comes and asks,
Do not ask us,
Yes,
tell
please,
us.
please tell
yeah,
us.
if a patient comes and tells us that, I do not want to take so many drugs,
Yes.
I want insulin.
Yes.
What is your take on
Right.
pre-mixed insulin?
I will come there. Rather than starting premix insulin, I will tell you, I do not know how many of you knows, when we are choosing basal insulin therapy versus there is another concept, basal plus insulin therapy, which is combination of either a co-formulation, premix, or separate basal plus 1 shot of rapid acting insulin with largest meal of the day. BMI comes into picture when we are choosing single injection. If you have, this is written in textbook of endocrinology, if the body weight of the patient is more than 120%, our patient is obese, more than 120%, then probably single basal injection will not suffice because that individual is going to have a significant prandial excursions. So if the lifestyle is such that he is taking a 1 large meal in a day, which is very common nowadays, rest of the day we are eating very small amount, then rather than starting a basal insulin, it makes a case either a premix or a co-formulation or combination of a basal plus a short form of. So it makes a case.
So again, our 20 minutes went only in glucocentricity. Again,
Rajeev,
and yes,
before
sir.
we go on,
Yeah.
will you like to reinforce monitoring? Lifestyle we always do at any level, intensification of therapy. monitoring. What I'm trying to say is, going by our own experience, with a fasting of 170 and PP of 210, with HbA1c of 8.6, it is tempting to speculate that there are equally or much more contributions to the prandial state for the lunch and dinner as well. So, would you like to certainly capture those data before harping on a mode of therapy, wherein I think your combination of a GLP-1 and a
So sir,
basal insulin.
fantastic question. And so the postprandial and the glycemic variability, it has been tested in an RCT called as a flat sugar study. And it looked at basal bolus versus GLP-1 plus basal insulin on the background of metformin. Both the cohorts, 250 patients in each, reached the same HbA1c target. But the patient who was on GLP-1 plus basal insulin not only had a better time in range, this is a 7-year study, so better time in range today, but also had a lot of reduction in inflammatory markers and 24-hour Holter's ECG abnormalities. So it's just a hypothesis setting that probably when we look at control, we also need to look at flatness of control. Today we have that TIR, but this study is 2015, that probably we need flatness. So an HbA1c of 8.6 could be 90 and 350 for all you know is fasting and
But
post.
then Rajeev, we are often talk about time in range, but I always wonder how many of our colleagues actually know what is current recommendations for time in range. Do we have some volunteer who will tell us what is the current recommendation for time in range for type 2 diabetic?
Anybody? I think he's throwing it.
No, time in range. 70% of that time,
Should be in 70.
70% of the
70
time, the
70.
blood sugar should remain in range from 70 to
180.
180 milligram per deciliter. There is another term, time above range and time below range. Those should also be there. That patient should not go beyond 180 to 250 and more than 250, which is less than 1%. Similarly, time below range less than 70 and less than 50. Now, time in range is a new concept, but again, measurement of time in range in real world in routine clinical practice is a big challenge.
So I'll again play devil's advocate here, that patient has proteinuria, hypertension, dyslipidemia. How many would add an ARB or an ACE plus SGLT2 plus a finerenone? Would it be added sequentially? Would it be added together like in heart failure you add multiple things? Would it be added in chronic kidney disease?
Well, the thing is, he's on a stiff dose of amlodipine, so scale it down to 5, introduce an ARB or ACE inhibitor of your choice, step up the maximal tolerated dose, and then probably withdraw, if possible, the amlodipine totally,
Right.
or even substitute with cilnidipine.
I will, thank you very much. This is a correct point. I will come to this. Actually, first of all, I will like to perform an echo in this patient. What is an ejection fraction in this patient? Patient has premature coronary history of premature plus other risk factors. So this actually makes a very strong case. He is obese. He might be having heart failure with preserved ejection fraction. He is smoker. So all risk factors are present. So echo makes a case rather than going for many fancy investigations. So echo make a case. We should do an echo, determine ejection fraction, whether it is reduced, mid-range or preserved ejection fraction.
Would anybody like to add an aspirin for him? Yes. We would like to add an aspirin for him. So we may get his HbA1c from 8.6 to 7.5, but we will change him to an ARB, maybe reduce amlodipine or knock out amlodipine, maybe add an SGLT2, which we will add for this particular patient, knowing that proteinuria is the driver for chronic kidney disease. Statin dose we may...
But I'm stopping one drug we are forgetting. There are enough data, and there are actually, this is a very old drug. It has shown benefit in reduction in cardiovascular. It reduces your postprandial glucose, and that is alpha glucosidase inhibitor. How many of you have experience and are willing to use alpha glucosidase inhibitor?
So alpha glucosidase is like something which you don't acknowledge on the podium, but you write in your clinic. Because the postprandial the reduction it gives you, and all of us are eating so much of carb. So there's data to suggest that it works better in DPP folks, and all the incretin works better in Indians or East Indians as we are called, other than Caucasians. So because GVK is signaling to me that, so patient injectable may be basal or basal plus or basal plus GLP-1 or only GLP-1 if somebody wants it. We remove the amlodipine, we get an ARB, we add an SGLT2 for this patient, we add an aspirin, we increase his statin.
But my question to you is, Rajeev, now all SGLT2 inhibitors are out of patent, they are generic. Cost is not a big issue. So which SGLT2 inhibitor you want to add?
So-
Empagliflozin, dapagliflozin, or even for that sake, canagliflozin?
So you gave me a googly. which
You
means
gave the
she-
answer.
Huh?
The generics are available.
So important, important in all the CKD studies, the eGFR has not been here. So EMPA kidney has 38, DAPA has close to 43. But EMPA kidney has more patients who have less severe chronic kidney disease and less proteinuria.
DEPA is
You know?
ideal.
Eh,
DEPA is ideal for
where is?
dapagliflozin.
Yes. So looking at this where the proteinuria is low and the eGFR is high, so the mild CKD probably an empagliflozin maybe.
So Rajesh and Rajeev, if you permit me, can you just sum up
Sure,
the
sure.
discussion
Yes,
so far?
before
Anything-
we
yeah,
sum up,
please,
sir, before we
please.
sum up, one last, because otherwise we will be not discussing that part, and that drug is available, and injectable form is actually, just to inform the house, injectable form of that drug is approved by DCGI way back in 2022, but the drug is in shortage. The company is not in position to market and come that drug into the country, and that is semaglutide. And now it is available as an oral form of semaglutide with host of advantage. We have said price, we are discussing science. We are not discussing price. So, no, he is not alcoholic. Alcohol nowadays, no. So how many of you have a take on starting semaglutide in this patient, considering obesity, considering CAD, considering dyslipidemia, and other issues? How many of you are patient can afford anything? He want best therapy. Yes.
Sir. Here, sir, one thing we have to say, step up wise, because costly treatment immediately keeping on is not necessary, because the CAD is in a mild to moderate, not moderate to severe.
How do we know, sir? We have not done TMT. We have not
we have
done
not
risk
evaluated.
stratification.
That's the thing. If the severity is more, you might have mentioned it.
So in this, I think this case beautifully presented by both of you and with excellent audience participation. It's a common garden variety, a diabetic of 10-year duration with 3 molecules on board. First, we'll talk about the glycemia. 3 molecules on board. The clinician's target is to achieve HbA1c of less than 7 if it is achievable without the risk of hypoglycemia. So a single molecule in the oral space cannot do this job, and maybe a combination of a DPP-4 inhibitor and SGLT2 also. So the options are, number 1, either a sequential or a simultaneous introduction of a small dose of a basal insulin, de-escalate and if possible try to eliminate the sulfonylureas, introduce an SGLT2 and a DPP-4 combination, or if the patient can afford a GLP-1 receptor agonist and a basal insulin. That is from the glycemic point of view.
Summarized. Thank you very much.
Certainly.
you, sir.
So this is from the glycemia point of view.
Thank you so much.
So from the point of view of the comorbid conditions, the patient is in CKD A2, G2, right? So he is a candidate for accepted interventions in DKD, which are, number 1, we have already discussed ROS blockers, number 2, SGLT2 inhibitors, and number 3, subsequently are going to be prepared for intensification of insulin dose. The touch of SGLT2 will help you to achieve the target with less amount of insulin. Third is, as Lakshmanan pointed out, with a family history of premature coronary artery disease, is the statinization adequate enough? If you want to achieve a 50%, I think nursing and authority is there, you're going to discuss with next Jugalbandi. So this will form the complete multi-centric approach in this wonderful case presentation, beautifully taken forward
Thank
for
you so
much, sir.
discussion
Thank you.
by Rajeev and Rajesh. Please give a big hand.
Atorvastatin, is it given HS or OD? Atorvastatin, HS, but it is put OD,
OD and HS dose.
HS dose. Okay.
Thank you.
Then
Thank you so much.
can we add pioglitazone and no, yes.
Discuss that.
I was in Supreme Court, ஒரு Tamil lawyer. He is exactly like this. I said, you should be on insulin. Our Madras, Delhi, he is coming to Chennai. There, reputed, they said, you are not, this is not the right time to start on insulin. That is why we come and fight it here. Thanks to the influence of industry, people are getting cocktails and ignorance. Okay, this is contributes to the morbidity of the nation.
Thank you.
Thank
So
you.
thank
Thank
you
you
all
for your
the
final comments.
Nice introduction.